So I want to introduce our presenter, Dr. Neal Lyons. So Dr. Lyons has been practicing as an emergency medicine clinical pharmacist for more than a decade, and has been on the Antimicrobial Stewardship Committee for various different institutions where he's participated in antimicrobial stewardship work. So very excited to have Dr. Lyons with us here today.
Thank you very much. I am going to trip over these cords, okay? So at least I might give you some comedic relief there, okay? I come in at you like the energy and enthusiasm of a gold retriever. Do we have anybody who works in emergency medicine here? My people, yay, okay. So I did not know who was going to be attending this. If it's, people who work there and understand the struggle, or people who are going to basically ask me why we do the things that we do. So I'm going to try to explain the plight of the emergency department. Maybe you'll have a softer spot for us, and that it is, in fact, probably the best place to start antimicrobial stewardship if you haven't already had a presence in there. I have nothing to disclose except that, we're all working in the post kind of COVID era. I have not worn a belt in over 3 years, so I go to work in a t-shirt and stretchy pants, so this is like a tuxedo for me, okay? All right, here are the objectives. So we're gonna discuss the importance of it, of course, right? Some elements to it, and list various approaches. And please, it's a relatively small-ish group, just shout at me. If you're too polite, raise a hand or whatever. This could be very interactive. I would prefer it that way, please. Okay, so most of you are not in the emergency department, so I want to welcome you to the emergency department. We have a lovely bed in the hallway for you, and by bed I mean like military-style cot. Please change into this starchy, scratchy gown. You're in the hallway. You are not afforded any privacy. And then please get your non-slip socks on. We don't need a lawsuit. And then, of course, your standard issue turkey sandwich and Gatorade. And then, of course, Zosin and Vank, or as we say, a dose of Zosin, a spank of Vank, okay? It's only a little bit of a caricature, you get it. We try not to do it, but I do want to express what we're up against in the emergency department, okay? Over 130 million visits in this country to the ED in 2020. That's about 40 visits per 100 patients. That's insane, right? Of course, there's overcrowding. ED is a safety net where we take all comers, right? And unfortunately, patient satisfaction scores are tied to reimbursement. And so there is inherently, regarding antimicrobial stewardship, potentially a conflict there where there might be some pressure from individual providers to make sure that those patients go away like we did something, for them. So I always say that the ED is the cross-section of society. Like I said, we take all comers. And so this is just a schematic of the types of patients broken down by age group. So the number one group of patients that come to the ED are less than 1 year of age. I have 2 little ones, and I can tell you that I've seen the inside of many immediate care clinics. And then greater than 75 is the next runner-up. But I want you to see that there's a pretty even distribution around there. So it is truly the cross-section of society, and we have to have such a breadth of information because we are taking care of such a breadth of patients. Additionally, speaking of the spectrum of patient age, but also patient disease state, right? So it's where ambulatory care meets acute care. I always have said throughout my career that, especially with like young learners, and they're all excited, oh, the ED is gonna be fast paced and all that. 80% is ambulatory care, right? A lot of that could have been handled in an outpatient setting. Yes, the ED is an outpatient setting, but maybe primary care, urgent care, something like that, right? So 50% of all medical care in the ED or in the US is performed in the emergency department. It's wild. And all 80% of all admissions come in through the ED. So it is just the bottleneck and for care in this country. I guess 80-20 rule, it's actually maybe even off than that, right? 14%. So pretty high amount that we are going to send back into the community. So with all of this, it is the perfect place for antimicrobial stewardship. More than 10% of the reasons why people come to the ED are infection related. Look at how many antibiotic prescriptions per 1,000 people, just in Illinois. And various studies have said various percentages of the appropriateness of antimicrobials that have been prescribed. So I would say that 30% is a conservative number, but really 1 out of 3, once you're getting to those numbers, that's impressive and needs to be addressed, right? And then also, there's just a high rate of adverse events with antimicrobials as well. So the culture of treat and street, right, of the emergency department, well, the treat and street needs rules of the road. And those rules on an individual level are the 5 Ds of antimicrobial stewardship. And we heard this in an earlier one, but just going through again, diagnosis, drug, dose, duration, de-escalation. Here's some. I'm not a diagnostician, so my apologies to my provider friends in here. But how many times have we seen maybe something like this in the chart, right? Where we're worried about hammering down this diagnosis. There's going to be a differential of diagnoses, right? And you have to try to determine which one is the most likely. And the biggest one then would be like a respiratory infection. Is it viral versus bacterial, right? So how many times have we seen in the chart, chest x-ray is normal, but is it a developing pneumonia? And then thinking about, are the symptoms consistent with, the disease process? So we heard a lot in the morning sessions about asymptomatic bacteriuria. That is a huge problem, right? And so no urinary complaints, but there's trace lukes in the urine. We'll follow up with a culture, but we'll start antibiotics. And then infectious versus non-infectious, right? Inflammation and infection are different and interrelated. And so you likely can't have an infection without an inflammatory process going on. And so sometimes there are mimics to infection, right? Stasis dermatitis is one of the biggest ones, I would say, just anecdotally, from my career, where you have bilateral, very similar mirror images of one another, lower leg looking inflammation, potential cellulitis. Is it a superimposed infection on top of their stasis dermatitis? So it becomes quite challenging. And then drug, right? So we have to think algorithmically in the emergency department. There has to be so much throughput that provide the providers with some algorithmic flow. Adopt an if not, why not drug selection instead of, I know one drug that covers many things. And so I'm going to remember that one drug, right? And so think about nitrofurantoin for acute cystitis. If not, why not? Is there renal function less than 30? Do they have pyelonephritis, right? And we can use antibiograms to then help assist us with thinking algorithmically and kind of providing a framework for the providers. Then dose is huge, right? You have to think of this dynamically. Renal function, obesity, the biggest one, I think, is pediatric weight-based dosing. So I am involved in culture follow-up, and so I review what was been given to patients. And when we overdose patients on the appropriate dosing for an infection, they could easily come back to us with an adverse event. And then also they might come back to us if we underdose because we have failed to treat. In obesity, things like data with a BMI greater than 40 for strep-like cellulitis, Keflex should be a gram Q6, right? Who's doing that? Nobody. All right, duration. Old guidance dies hard. And this is kind of the problem with a lot of what goes on in the ED and overprescribing. The durations for this were, people sitting around and going, okay, is a week good enough? Let's do 2 weeks. Right? So when these antibiotics came out, we're just guessing, right? And so it's difficult to then have that be, practiced for decades. New data comes out showing, well, man, intra-abdominal infections, 3 days, 5 days, right? Instead of this 10. So, and in a perfect world, these people would have wonderful follow-up, and we can opt for a shorter course as long as they have a clinical reevaluation. And of course, de-escalation. So in the emergency department, this is most commonly done in culture follow-up. And that is the biggest thing. Review cultures, look at what was given, see what is grown, and see if we can either change it up. But additionally, this is when that 14% gets admitted to the hospital, right? And we're following up on lab values that we have. Also with, de-escalation, going back to inflammation versus infection, right? Our markers for infection coincide with inflammation. So if I stub my toe and I'm tachypnic and tachycardic, right? Maybe I even had, it was so severe that my acute phase reactants, went up. You have an elevated white count and platelets, right? So you could have these sepsis mimics that are also confusing our emergency department physicians. And then this is very common and something that is difficult. I want you to appreciate that when somebody comes in, we have no information about it. And I love when I have infectious disease pharmacists on rotation with me because they get so frustrated about the lack of empiric information that we have on these people. We're, working them up as the patient presents. So there are no notes yet, no labs resulted, no imaging. It's all pending, right? And they're like looking back and like, there's nothing in their chart. Yeah. I know. So by the time that the admitting physicians come in, we're hoping that there is more data to rule out, and change the differential a bit. So continuing antibiotics that were given in the ED, please don't. With the pressure for rapid treatment of sepsis, that is also kind of shot ourselves in the foot. That we have a very low threshold in order to initiate antibiotics, and then we go, yeah, we have no information, and but they might be septic, so we need to use antimicrobials. So as I was saying, is it a treatment failure, or was it a failure to treat? And so taking the rules of the road, hitting a U-turn, back to the ED. Like I said before, renal function, obesity, maybe we didn't optimize that. Duration, dose, mismatch, drug interactions, compliance, lack of follow-up. Adverse events, right? And just as I said, returning back here, almost 20%, 1 out of 5 is causing an adverse event from this. That's wild. And it's the second most common cause for adverse drug events. The first class of medication that is the highest return rate for adverse drug events? Opioids, and it's like the gun problem. It's like opioid epidemic. It is an access issue. So 1 out of 1,000 prescriptions results in basically an ED visit is another way to say that. So a challenge question that is not very challenging. Education of individual providers on all the things that we just said about the 5 Ds of antimicrobial stewardship is enough to produce long-term results of AMS initiatives. What do you think by that leading question? Okay. So we have to think about this globally. Individually, education is so important for providers, and that's where a huge role of Antimicrobial Stewardship Committee is, and it needs to be continual. But the passive education, you'll see short-term gains, but then it will fade after some time. And so you have to keep re-educating, and that's why it's so important when you look at core measures of antimicrobial stewardship. As you all know, it's feedback is a huge deal, so that's always in their mind. But we can't rely just on the individual. And remember, in the emergency department, it's shift work, right? So you have so many physicians who have to cover 24/7. It is not an outpatient primary care group of 5 to 10 physicians that you might have a little bit tighter control and being able to standardize things. So you have to go to the system level. So let those system interventions support the individual. We're going to go through all of these. So take a look at these, and we're going to go one by one on the system level interventions and how we can kind of pertain it to the emergency department. Starting with multidisciplinary collaboration. And this is like, I'm just hoping that I could provide one or two nuggets for you guys to go back and say, all right, great. The biggest thing is to have an ED antimicrobial stewardship champion physician. Usually you could contact their medical director, and then they could probably assign from there. I think it's so important to have this person be the contact for the emergency department. And when relaying back feedback, they can have a physician-to-physician discussion about that. It's not this guy coming up and saying, Dr. So-and-so, you prescribed so many Vancos, so many meropenams, stop doing it. That doesn't hit the same way. So if you really want it to be effective, you need some buy-in from the emergency department, specifically a physician. And of course, all of these other people are wonderful as well. Administrator support. If we have any administrators out here, I know how hard it is to justify kind of cost savings rather than money making, right? But I can point you to 50 studies looking at how we can save money, save time, enhance throughput through the work of antimicrobial stewardship, through having an ED pharmacist there, okay? And again, it might be an upfront cost, but we have a long-term value for that. Okay. So like I said, a culture review in the ED. Is anybody of the two people that raised their hand involved in culture review? No. Do you mind? I'm going to put you on the spot. Are you a pharmacist? Who doesn't? Did they ever come up to you and ask you complex ones or anything? Rarely. Okay. What do we got back there? Mid-levels. Okay. Yeah. They are a wonderful resource. I think that's a great process for the mid-level practitioners. I would urge you to have a pharmacist in the process. And I was at 3 different hospitals where I was not in charge of the culture review. But they would come back with like, hey, I got this weird case. Hey, what do you think about this? And they were very comfortable about asking for any sort of advice on any of that. And so even if you're not exactly involved, you could still be kind of adjacent. Very cool. So this is one of those low-hanging fruit interventions. I mean, if you go back and to your hospital and the emergency department has, a binder where if they remember to write down a medical record number of the patient and remember somebody's going to follow up tomorrow to go through that binder and everything, try to automate things and try to formalize that process, see what that process is, because there's probably a lot that can be improved in it. And even at the place where basically I'm owning that, there is still, it is still ripe for improvement for sure. And also, like I was just getting at, interdisciplinary collaboration. And so, if they're going up to the physician is aware that antimicrobial stewardship is an initiative that's happening in the ED. That is always really helpful. And I think I've had so many conversations with patients where they are just so thankful to get the time on the phone after their follow-up. So that's what I'm saying, a second chance at a first impression. And not only through the medication, where we prescribe something that it was resistant to, and we can correct that and prevent a return to the ED, but also these patients are so happy just to hear hey, how are you doing? And like, oh my gosh, right? It's great. And they're more receptive to then stopping those antibiotics when you can have that conversation, following up and saying, hey, yeah, they thought there was maybe a UTI, right? But you're not telling me that you're endorsing any symptoms of that. So you can go ahead and stop those antibiotics. I mean, they're just going to cause you more harm than good, right? So that allows for some patient education, right? Follow up. And like I said, the biggest thing is try to implement systems that will provide consistency over a place of shift work. Okay. I mean, I'm at a place where there's like 20 physicians in and out of the ED. I mean, it's wild. So trying to track each one down is tough. So provide them with system solutions, right? Shameless PharmD plug, this whole thing. Sorry. Okay. The reason why I want you to get involved is that it has been shown pharmacists like love reports, okay? And they like love meetings, like, gosh, just they'll be so happy to do this for you, you know? So it's been shown to save physician hours per month, 50 hours per month that these physicians can be working on throughput, treating other patients, right? Increased interventions relative to other care providers, decreased time to culture review, and then decreased readmissions. Yay, pharmacists. If your institution doesn't do this already, it's a must. It is an ED specific. You have to have the time and dedication to have somebody tease out the ED antibiogram versus the hospital one. Like we said, over 80% are basically getting discharged from the ED as an outpatient. And so you know that those bugs are going to be quite different, right? And like we said, the cross section of society, so many different types of patients, it's heterogeneous, right? You also need to guide empiric therapy, see if we can cut it down. For instance, in the earlier section, right? Too much ceftriaxone, getting sent home, do cefazolin, and then send them on Caflex, for instance, something like that, right? And trend the resistance over time, super important, as they were saying. Differences in susceptibility. Look at that number. That is wild, right? I mean, 10% difference from people who leave the hospital after visiting the ED versus who stays in there, 10%. I mean, it's unacceptable to empirically use a drug that has in your community over 20% resistance rate, right? So that is large. Like I was saying, it's an access issue, okay? So use your formulary, all right? And nobody says that you can't have an ED-specific formulary. Now, you might be at an institution, and I've been at a few where the way to verify medications, now this is in the weeds for our pharmacists, it might auto-verify, right? Anything ordered in the ED, auto-verified, they could get out of their automated dispensing cabinet, right? Their Pyxis or Omnicell, and it's just, nobody reviews it. And so there's quite a few things that you can do in your ED to restrict that. One, if you've got like, I don't know, meropenem in your Pyxis, don't in the ED, okay? You know, that might have to go through somebody. That should be a check. But I've been at institutions that it's auto-verified because you're like, well, we can't delay therapy. You could probably ask a question about meropenem. I think that's valid, right? You get patients got time for that, I think. Okay. So you can even restrict it based off of not having it available then in there if your system is unwilling to have all the ED orders verified. Okay. You can actually team up with your IT. I've got a couple of slides in here where it's like my love letter to informatics. Anybody from informatics here? No, man, we got to get him out here. All right. Well, if you know, just be like, wow, this guy was really infatuated with them. They can even set based off of what specialty the provider is to what they see when they type in medications. So type in meropenem. I can't find meropenem. That's right. You can't find meropenem. It's not for you. Okay. Other things that they can do. If you don't have these resources of having an infectious disease physician, we actually have, it's kind of nice. We have a tiered system for approval where there's ID pharmacists there. And we have a residency class of pharmacy residents and everything that carry over after hours. But it's a pager for pharmacists. So there's a bank of antibiotics that they can approve. And then there's some that are a top tier like Abicaz that we're not allowed to do that either. They need an infectious disease physician, right? But mandatory indication. So if any of that is like, no, you're getting pushback from administrators and everything, have them put in a box of mandatory rationale upon ordering at least. And then that way you can actually track. So when you run a report on all the Vancos, what did they actually say their reason was, right? And that reason should most likely be like intra-abdominal, So there's some options there. And then certain broad spectrum or expensive antimicrobials, just non-formulary at all. They need a phone call down to, the pharmacist or what have you, and get approval that way. The unsung heroes. And look, unsung, none of them are here. I'll sing for them. They can help with things like UA to reflex. I don't know how common this is. I have a slide on that too, where it is a double-edged sword. We were just talking about this, right? Where asymptomatic bacteria is such a big deal. But order set optimization. If you have, an ED specific order set that just says antibiotics and just lists them alphabetically, don't do that. Because you know what's going to happen? Everybody's on azithromycin and aztreonam. Perfect. Community-acquired pneumonia. I did it. They can help with doing subcategories of everything. Again, think algorithmically, okay? They have to see so many patients in the ED. Help them out. Anecdotally, physicians, they want to do the right thing. They want to do the right thing quickly, and they want to move on, right? So you just go, okay, follow this order set, and it'll go down, right? Community-acquired pneumonia, that's what they have. You go, do they have a penicillin or anything? No, okay. And we can talk a lot about that. Give them a flow within the order set, okay? You could even embed links into practice guidelines. You have to remember to update your practice guidelines when you do that, but in at least Epic, you can link right there, boom, goes to the web and shows them an algorithmic workflow. So we actually just changed our pediatric intra-abdominal workflow. It links right there, works nice. Big one, and listen, there's only so many hours in the day, okay? So let me give you an example of a default dose frequency duration upon order entry that is not optimized at my institution, and that would be metronidazole. It defaults to 10 days. Why does it do that? Old C. diff guidelines. It's just stuff that you just can't always get to, but try to optimize pre-checked, and IT can do this, pre-checked dose, the most common frequency, and duration. That can all be pretty much pre-populated as a suggestion there. And then, of course, they can help you out with culture follow-up reports and all that. I told you. They're important. They get 2 slides. Allergy clarification. Why don't we have it mandated that they have to write in what the allergy is? It's not just what they were allergic to, penicillin, and then not have to say what happened to it. Make that a mandatory field in there so that we can at least help navigate allergies and so that we're not relying on fluoroquinolones all the time. Pop-up alerts, best practice alerts, pop-up alerts with a specific antibiotic that says, hey, if they're like, hey, you can't restrict meropenem, an ED physician might have to order it, fine. Put it in a pop-up and say, these are the approved indications. Are you proceeding? Yeah. Okay, but at least it's another alert for them to say, hey, this is what we're reserving it for at our institution. Talked about auto verification in the ED. And then what I would love to do, and if anybody's had success in this, this would be great, is suppressing susceptibility results or having with lab trigger releasing more susceptibility for more drugs based off of resistance of the most common ones that you want them to use, right? Mull that over. Let me know if anybody's had any success with that. And then, of course, tracking the use of restricted antimicrobials. They can generate reports for you that happen automatically. Okay, IDSA, everyone recommends facility-specific guideline creation, right? What works for you? Again, you're putting hours into this, they're going to feel like, okay, this is my baby. So that's why you need that ED Antimicrobial Stewardship Champion to help with this. It's collaborative. We're going to say, yeah, I put a lot of hours in this, so we're going to use it, right? And then, of course, make sure that it's for the most common ones, and we'll go through disease-specific ones later as well. Once you allow those guidelines to happen, right, you start then reducing the individual decisions that each individual prescriber makes. And then ongoing assessment. Everybody knows this. You're here at an Antimicrobial Stewardship Summit. Just make sure that you are inserted specifically for the ED in their QA, QI, quality assurance, quality improvement meetings. Okay, they're going to have those. So if you're unaware, contact the medical director and say, hey, when do you have your quality assurance meetings? And I want in on that. We are going to have a specific line item every month for antimicrobial stewardship. And then if you have a emergency medicine medical residency, I'm fortunate enough to have one here. That's always really nice because you can shape these young, ambitious minds of the residents, and then that will be a nice feedback to the attendings as well. So have a presence at that conference. Usually it's a weekly conference, right? So get in there once a month, quarterly, what have you. Make sure that they know that this is part of the entire culture in the ED. Okay, so disease-specific antimicrobial, right? Target the big three. If you have no antimicrobial stewardship presence in the ED, this is it, right? This is where you start. So respiratory infections, number one reason why there are misprescribed antibiotics, right? Viral. So non-bacterial respiratory infections, highest misuse. I don't know why I put otitis there. Those aren't your ones. You get the idea, though. It's viral. Use of diagnostic aids. So when you're manufacturing these order sets and everything, don't forget, pre-check some of these if you want. Leave them as an option. Viral panels, strep, MRSA, right? Procal. And I think there's a later one that's all about kind of emerging diagnostics. I know that actually at our institution, we're going to be trialing one by diasorin, which kind of uses like a weird host response, which should be hopefully very exciting for diagnostic aids, because as we all know, getting sputum culture results is one, challenging, and two, very low yield. But it is recommended by the CAP guidelines, right? All right, so looking at education and adherence, again, these old habits die hard. So, right, there was an update now years ago to the CAP guidelines looking at gram of amoxicillin 3 times a day. Who's doing that? Sending them out, right? Well, you got to raise awareness. Let them know that there is a change in practice. They're not receptive to learning. And so look at this. I mean, they just saw skyrocket 30% to 85%. And of course, then a subsequent decrease. Urine cultures. The bane of my existence, because I do the reports. So every morning I come in and there's like 5 patients who, we had some white cells in the urine, some leuks. So it triggered UA to reflex a culture. It grew something, but they were here for a motor vehicle accident. The reason why they got urine was to test them for drugs to see if that was causative of the, of the accident. Not like, oh, my flank pain from my pylo, and then they like weave off the road, right? So it's important because you are not going to miss one, right? If you rely on each individual to then say, I want a UA and a culture, the risk is that they're going to go, I want a UA, look at it, be like, yep, all right, that's going to culture, and it doesn't, and then we're flying blind when somebody legitimately has a UTI. But as I just described, you're getting a lot of increase in antimicrobial, asymptomatic, bacteriuria. So I think it's so important too, and I've caught quite a bit just anecdotally that as you follow culture up, I mean, there are some that go, yes, symptoms of a UTI, well documented in there, definitely growing something. I get to it, it's been 2 days since they've been in the ED. You call them and they go, I feel great. You're like, I don't know how, but wonderful. Thank you. Great. And then you catch them and they go, I feel miserable. I know why. You have a resistant organism. So adjusting the therapy is so important. This is a big one. Again, get IT on board. Is removing UAs in order sets that don't necessarily have to do with an infection. So the biggest one, and I guarantee probably in all your order sets, is going to be a UA, and that UA is probably 2 reflex, and it's probably pre-checked for generalized abdominal pain. So when you're starting out, I think it's a good way to find the scope of the issue by looking at all your ED specific order sets and running the list. And what happens, and I've had these conversations with nurses, with the physicians and everything, and the physicians will be like, don't do a UA, they don't have symptoms of it or whatever. And they're like, it's in the order set, it's pre-checked, it's already been done. You go, okay. So definitely get those UAs out of those order sets. There has to be intent with those. Like I said, skin and skin structure infections, right? Dermatitis versus infectious causes. I think there still might be some either lack of guidance, or I would say maybe just professional judgment on who gets antibiotics after an incision and drainage without strict criteria. So that could be something to put in a facility specific guideline where, you know what, you did an IND, think you got it all. This person is young, healthy, no signs of systemic infection or anything like that. Do they need these antibiotics? Well, knowing, say, hey, you did source control. Have that conversation with the patient and say, this comes back, recurs, gets worse, then either come on back or contact your PCP. But not every IND needs antibiotics. And please, the spank of the Vanc, don't do it, okay? One-time dose of Vanco. That has to be heavy. I still see it. This has been so long, 10 years, and people are still doing 1 dose of Vanc. We all know, pharmacists, doesn't work like that. All right, another not so challenging question. A bundled approach to antimicrobial stewardship in the ED is an effective strategy for long-term results of AMS initiatives. You betcha. You betcha. And they touched on that in an earlier one as well. That bundling is so important. And so, I don't just do shameless PharmD plugs, okay? I respect my colleagues. And so this was a study, not a study, a narrative review of available antimicrobial initiatives that had a bundled approach. And that means the education, right? The 5 Ds, accountability, all of that, system changes, all of that. So they did a narrative review on that, included 25 studies, and they go by disease state and they go by interventions as well. So I implore you to take a look at that. It's a nice little summary of the successes that have occurred specific to the ED. And yeah, it's from my colleagues at Loyola before I got there. 2019, it's good. And then any additional resources, right? I mean, literally, if you just Google like antimicrobial stewardship in the ED, there's a million things coming up, right? So this is just hopefully some little nuggets for you and everything. And then of course, just like was stated there before, the core elements of antimicrobial stewardship, you'll find ED specific things in outpatient. Remember, ED is an outpatient facility. Some people go inpatient. And it'll have clinical facility checklists and all of those wonderful things. And then of course, IDSA, they're lovely. Okay, and then there's a secret 6th D, is do that research. You don't have to be at an academic medical center to conduct quality assurance and quality improvement studies. Epic can tell you, it doesn't have to be big. Take a sampling of 50 Vancos, right? and look at what they were used for and all that, right? So do that research. MUEs are great. You got pharmacists, they love doing MUEs. Give it to them. Yeah, medical pharmacists, residents love those as well. Students love those. Tell them, listen, anytime you say to like a pharmacy student, yeah, you get to put this on your CV. And they're just like, yes, you know, oh, I'm going to look so important. Look at prospective outpatient prescription reviews. So something that I'm interested in, they're the next two lines here, that I'm trying to get done at my institution is we don't have any pediatric prescription review upon discharge. It happens upstairs when they're admitted. And then upon them leaving the hospital, it goes into the verification queue for the pharmacist, and you can review what it looks like before it gets electronically sent to the pharmacy of their choice to get it filled. And I go, wow, we already have this process in place. Get that in the ED, let's go. And apparently it's a, I don't know, technology nightmare to do. And so what I'm going to be trying to do is having it be a little bit low tech and just say, hey, when you're discharging a little 5-year-old, can I look at the prescription before they go? Because what ends up happening is I'm doing the culture follow-up, and there you go. You know, your Ceftonir 7 mg per kg Q12 becomes 14 mg per kg Q12 and all that, right? And then because we try in the ED, okay? We try to narrow the spectrum as best we can with the information that we have. And something that I am interested in, and this is all free for all of you, any pharmacy residents you have, anybody wants to get the study out before I do it because I'm not that motivated. If they initiate a lower spectrum agent in the ED, and then the admitting team comes in and broadens coverage, looking at if that was an appropriate escalation, because we're fighting against it, and I have to, harass our physicians and go like, they don't need pseudomonal coverage. Stop with the cefepime. Let's do ceftriaxone for this community-acquired pneumonia, whatever it is. And then they're like, yeah, well, they're going to the MICU, so Zosyn Bank. And you're like, well, it could still be the same causative organism, and they're just very sick. And so that would be, I think, very interesting as well. And you could just have pre-post internal data as well, right? You start an antimicrobial stewardship initiative, look 6 months before and 6 months after and all that. So do that research. Okay. Number one thing, find an ED physician champion. The 5 Ds are going to help guide any of your clinical decision-making support, your guidelines and all that. System solutions, decrease the reliance on the individual behavior. And like I said, right, you might be coming from a long-term care facility that has maybe a few physicians that you can kind of wrangle. But a lot of times it is just staff work in an ED. Oftentimes they are contracted with a larger group that serve many EDs. And so you need somebody plugged in to that system there. Low-hanging fruit first. Heard that a few times, right? The big 3, respiratory, urinary tract. I would actually say urinary tract infections first. And just investigate what their culture review process is. I've been in institutions where it's up to the physician, and they'll be so busy. They're like, I have not gotten to this yet, and it's 5 p.m. now. And so helping them with that, they love it. I mean, they love that I do it. And it's ultimately the physician at my institution who's in charge of it, the 7A to 3B doc. Well, once 11 hits and it's just chaos in there, and they're going to be like, didn't get to it. So then it kicks it to the next day, right? So get tapped into what their process is. And then ongoing assessment and accountability, specifically with that ED physician champion as your conduit for your antimicrobial stewardship committee. We'll keep that going. Thank you for hanging with me. Are there any questions, comments, concerns? Yes.
So by the
I don't
time
need this mic.
antibiotic stewardship is functional or actually starts to work, the patient is out in the ED.
Well,
Either gone up to the floor or home.
Unfortunately, potentially, if they're going home, yes. But I will tell you that ED overcrowding is a global issue, and I have ICU patients in my ED for 2 days. So a lot of times they are still in the ED, and it's been like an increasingly worse problem, ED overcrowding. So it's very common that I'm coming in, I did a Vanco note on somebody, and I'm in the ED. The next day I come in and I'm like, still here, you know? And so I'm the one doing follow-up. I'm like dosing warfarin for the next day. It's insane. So very commonly they are actually kind of stuck in the ED. But yes, that's why I'm kind of interested as well of like, okay, we've been trying to wrangle in the ED physicians. We got them to do lower spectrum agents for what they normally would do, anti-pseudomonal coverage or something like that. And then boom, they go up and their coverage gets broad. So that's why
It's just that it's a little harder to find patients who have gone out of the ED back to the floor or back home because it's very difficult and no one wants to own who needs to call the patient for their lab results.
Oh yeah. I've had so many uncomfortable conversations about STD diagnoses. You know, it's been like a Maury Povich thing where I didn't know. I was like, you know, on speakerphone and they're like, see? So nobody really likes that ownership. And I would say if it is owned by a physician, they have so many other things to do that it should be offloaded to another service provider. So if it's a mid-level, right, APN, great. One place I just had, it was a designated callback nurse, and that was her job. And then sometimes, you know, here currently it's pharmacist and then backup physician ultimately. But that has to be a standard process. So I guess maybe this will help too. We use a third-party system called MedMind, BD MedMind. I'm not endorsing them. It's not a super great name, but anything that's positive, it captures. And I would prefer, in the throes of COVID, 50 patients with COVID on a report, right, from the day prior. And we're not doing necessarily anything in the early days for that, but at least every single positive result of some sort of infection populates on that report.
We use MedMind. Trust me, it does have issues, but it's good.
It's good. Yeah.
Yeah, I'm not disputing that. My other question is, any thoughts on how AI could be applied to ASP?
I don't think that our current electronic medical records are good enough to support any sort of AI. I think that, yes, I actually think I'm like a little bit of a self-deprecating pharmacist. I know I was like, hey, you get more, but I think like our job in the base level could probably be eliminated, that a machine would be able to detect interactions, clinically relevant ones, all that kind of stuff better than this guy. So I think there is a possibility. I don't think we're anywhere near where we maybe will be in 50 years, but I think there's going to be just decades of status quo. I don't know why in really the electronic medical records, you know, there's basically two that we use, and they're both like not great. And I don't know why there's no Elon Musk of Epic, who is then just revolutionizing, you know, this and everything. So I would say in the future, I don't know if it's going to be in our careers. But.
I get at least one EMR is looking into AI as possible.
Good. Yeah, right now, I mean, I can talk all about this with ChatGPT. I actually typed in to be like, antimicrobial jokes. ChatGPT, they were awful, unusable. But so, you know, it's a large language model now, so it's kind of tough to have it be generalized like that. But I mean, AI is so good at pattern recognition that I could definitely see it being.
I'm sure you know that they fed a whole lot of errors, data into the ChatGPT, and then it came up with a new antibiotic that actually tested good on Acinetobacter baumannii.
Get out of here!
I'm telling you, I haven't.
Did you all hear that?
It sounds so interesting, but yeah,
Wow.
That's what I heard.
Can I plug in and be like, what's a good stock to invest in? Would it do it? I don't know. All right, let's all get rich and get out of this hospital room.
Thank you.
Yes.
Can you speak a little bit more, because our ED is similar to yours and so far as what we have in several EDs are. Can you speak a little bit more in terms of relationships established with the admitting physicians? Because I feel like just it's a bigger bang for a horse's buck in terms of sitting in the ED and saying, hey, talking about the antibiotics, talking about home medications, but of course, obviously, we also have all the ED responsibilities.
Yeah, it's really tragic, I think, and I understand the workflow of the admitting teams is that they're going to round likely on the ones that are in their units or on their floors and then come down to the ED. And so there is often a delay with care with these poor forgotten souls that are just in the ED waiting for a bed upstairs, for sure. So at least at my institution, we're fortunate enough to have a paging service on our phone, an encrypted app that we could page the teams out for any recommendations. If we have a pretty robust rounding pharmacist, so like my colleague, I'll just be like, hey, check this out, you know, and hand off that way. But it's tough because it's very shift dependent, right? Especially if me being a pharmacist, we're all kind of working during the day. And we have some coverage in the night, but not enough. So it is tough. And I would actually say that is super important. If you're not in the ER, but you're in a hospital setting, please don't forget about them because there's actually been an increase in mortality when patients have missed their subsequent dose of antibiotics. So the ED, again, is an outpatient facility. These ED physicians do not have privileges in patients. Okay, so their orders shouldn't actually be continued on inpatient. And that's why we deal in the world of once. I always say you'll see these once doses of antibiotics. Let's say you're not doing extended spectrum Zosyn, and so it's Q6 hours. Well, it's been 12 hours since they got their first dose. So there has actually been an increase in mortality when they miss that second dose. So it is super important to not forget them. And so that's part of my morning routine. I get there at 7 and I troll for all the missing antibiotics if they're still obviously appropriate. Yeah. It's tough though. And so, yeah, it's all about transitions of care. And unfortunately, it's just the workflow of things. Usually they start rounding on these patients, at least at my institution, way later in the afternoon. Did that answer it? I don't know.
No.
I have a question.
Yeah.
Does your facility have ED-specific antimicrobial stewardship metrics or a dashboard? And if so, what are those? And what have you found to be particularly successful in tracking those?
Yeah, so I think like everybody, COVID derailed everything for a while, and we're trying to rebuild that now. And so this is kind of nice because it's like, I have to think about this now because I'm presenting at it. And so I'm like, oh man, that order set needs to be updated and all that. So we're kind of trying to recommit to it after all that dust has settled and everything. We are fortunate enough to have a pretty robust antimicrobial stewardship committee with several infectious disease pharmacists that are way smarter than I am about all of this, who track all of that. So our antibiogram is separated by the ED. We will send it out to their QI and talk about it. QI meeting, right? And talk about it, say, highlight, okay, look at this for E. coli, when you discharge them from the urine, Bactric is actually 96% susceptible. Your fluoroquinolones are 8. So it's highlighting that and trying to help change practice that way. Then these physicians need to just everybody read every email they get. No, and so it's still a bit of a fight, but teasing out that information has really helped. And then the antimicrobial stewardship has been proactive about like, hey, we got to relook at these ED order sets. You know, there's been a practice change and doing that. So, yeah.
I have a question.
Yeah.
Can you talk a little bit about ED physician utilization of order sets at your institution?
It's funny because if your order set isn't optimized and you come up and go, actually, can you do this instead? They're like, you told me to use the order set. I'm doing what the order set told me to do. So it's been jammed up about use the order sets. And you can actually, again, IT, you can actually prevent individual ordering of a drug just by itself. So they have to go through it. Devilish. So yeah, it has, there's some times, right, where it's like, well, I'm not gonna use a sepsis order set because they're not septic, but then they'll use it in the opposite way where it'll be like, I know that this is where I find antibiotics in the sepsis order set. I know they're not septic, and then it goes maybe a bit too broad. So it's tough, but yeah, I would highly encourage optimizing those and utilizing them.
What is your best reference? What do you use to make sure that your order sets are optimized? What do you?
Well, they have to be, and this is probably pretty standard, they have to be updated. Ours are actually every 2 years. I remember at other institutions, it was annually, right? But unfortunately, it is a lot of just like tracking going, there's an update to a guideline. What kind of downstream effects are those? Our practice guidelines that we link, in the order set, the actual order set, and that could take a long time for it. So unfortunately, it is required that we review them at a certain interval, but and administration is okay with reviewing them before that time is up, and I think that's important too. Say, hey, there's like a big practice change. I know we just went live with the new order set 6 months ago, and we had to go back in and change it. So yeah, your institution should have kind of a mandatory review time, but then ad hoc, as needed. Thank you all.